Sir, please start your session.
Okay, thank you. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor. This program is brought to you by Hetero Healthcare. Hetero Healthcare, as you all know, has got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experience Sharing Program on Managing PPH, we have got Honorable Speaker Dr. Srilatha Reddy with us today. Welcome, Madam.
Thank you, sir.
Dr. Srilatha Reddy is MBBS, MS Obstetric Gynecology, FMAS Fellow in ART, Karimnagar. Madam has expertise in handling critical obstetric patients, having practical experience of both in-house and outdoor cases of obstetric and gynecology patients. Worked as assistant professor in PIMS Naganur, Karimnagar. Worked for Morpheus IVF Center, Karimnagar. Has participated in Foxy International Conference in HICC Hyderabad 2016. Presented poster in TCOG Khammam in 2016, acute abdominal pregnancy. Attended a force training program held at PIMS Karimnagar. Presented paper in TCOG 2016 conference, clinical study of anemia and pregnancy. Presented journal on clinical study of ectopic pregnancy in PIMS journal. Case presentation on uterociliary pregnancy. Madam is member of Foxy and member of Society of World Laparoscopic Surgeons. With this brief introduction, I hand over the session to Dr. Srilatha Reddy. Welcome, Madam.
Thank you, sir. Thank you, sir. Good afternoon, everyone. Today's topic is on overview of postpartum hemorrhage and my experience with Carbetocin. Next slide, sir. So postpartum hemorrhage is an horrifying and disheartening dotting event which an obstetrician can experience. So PPH is defined as a loss of greater than 500 ml of blood in vaginal delivery and greater than 1 liter of blood following C-section, according to WHO. According to ACOG, a cumulative blood loss of greater than 1000 ml in 24 hours and associated with any signs of hypovolemia like low systolic BP, tachycardia, tachypnea are defined as a PPH. So PPH is a common and can occur even in a woman who had PPH is a leading cause of maternal mortality in low-income countries and the primary cause for nearly 1/4 of the maternal deaths globally. So PPH can be of 2 types, primary and secondary. Primary, which occurs within 24 hours. Secondary, beyond 24 hours to the puerperium. As you can see in the pic, first pic denotes a normal postpartum patient with well-contracted uterus, whereas the second pic, you can see the flabby uterus. So postpartum hemorrhage, it's an unfortunate event. Move fast, sir. So second slide, please. So postpartum hemorrhage is an unfortunate yet common. Next slide, sir. Next slide. So maternal mortality is the leading cause. PPH is a leading cause for maternal mortality, accounting to about 35% of all maternal deaths. So MMR is nothing but a maternal mortality rate in developing countries is 240 for 1 lakh live births compared with the 16 in developed countries. So most of the incidence of PPH has reported 2 to 4% in vaginal deliveries and 6% after C-section. So PPH incidence in India, nearly 38% of maternal deaths are due to PPH and 25.7% are global deaths take place in India and 2/3 of these attribute to the PPH. So India has unexpectedly high maternal death rate of 140 per 1 lakh live births. Next slide, sir. So coming to the etiology of postpartum hemorrhage, 4 T's are included where tone, thrombin, and trauma and tissue are where tone, 80% of cases are because of tone, where Uterus will be atonic, which leads to the continuous bleeding. Thrombin, any coagulopathies can lead to the failure in clotting. Trauma, any trauma to the vaginal birth canal like cervix or vaginal tears, or during C-section, any extension of angles or can lead to the continuous bleeding. Tissue, coming to the tissue, it accounts for about the remaining 2%. Retention of placenta and abnormal placenta can cause a PPH. So the tone, 80% of PPH was due to the tone, and 18% is due to the trauma. Remaining 2% is due to the thrombin and tissue. Next slide, sir. So what are the clinical findings in PPH? We can find abdominal tenderness, circulatory collapse, increased abdominal birth girth, loss of uterine contraction, maternal tachycardia, and vaginal bleeding. Clinical assessment, risk assessment can be done with the approximate blood loss measurement and blood pressure changes and symptoms and signs. We can quantify according to mild, moderate, and severe cases. Like for mild cases, 10 to 15% of blood loss can have a palpitation, dizziness, and tachycardia. Mild cases, nearly 1 to 1.5 liter can cause weakness, sweating, and tachycardia. And very severe causes can cause a collapse, hair hunger, and decrease no urine output. So other relaxed flabby uterus can account to the atonic PPH. Contracted uterus, but still bleeding, we can check for any trauma. Undelivered placenta, we can go for a retained placenta protocol, and no palpable uterus per abdomen we have to rule out inversions. All these are ruled out. Still bleeding, we have to keep in mind DIC. But still bleeding, we can check for any trauma. Next slide. Next slide, sir. Undelivered placenta, we can go for retained placenta protocol, and no palpable uterus per abdomen we can have to rule out inversion. So diagnosis of postpartum hemorrhage, the initial evaluation should be done with rapid assessment of patient status like pulse rate, BP, and assessment of blood loss can be done. So tachycardia and hypotension are noted when there is a greater than 25% of blood loss, that is moderate PPH. Examination at the time of hemorrhage should be done. Uterine atony signs like soft, boggy, non-contracted uterus. Assessment for entire genital tract for lacerations, hematomas, and signs of uterine rupture. Manual examination of retained placenta tissues for any retained cotyledons should be done. Assessment with bedside ultrasound to check for any clots in the uterus or peritoneal free fluid. Evaluation of uterus to check for uterine inversion should be done. Measure of blood loss can be done with the use of brass bead rate. Uterine inversion, if there is no palpable mass at the fundus and the fundal wall can be seen through cervix, then uterine inversion should be kept in mind, which occurs with excessive blood cord traction. So laboratory assessment should be done. Complete hemoglobin, hematocrit, blood grouping typing, and the blood product availability should be checked. So modified shock index should be kept in our mind and should be mild, moderate. Severe shock can be assessed with heart rate and mean arterial pressure. Next slide, sir. So poor approach towards the postpartum hemorrhage. If any poor uterine tone, the uterus feels relaxed, boggy, and soft, and uterus fundus can be felt above the umbilicus if the uterine cavity is filled with blood and clots. So investigations, coagulation profile, complete blood picture, urea and electrolytes should be sent. If a patient is not responding to fluid and blood replacement, ultrasound should be exclude uterine rupture and intraperitoneal bleeding. The manage can be done with uterotonic agents like oxytocin, prostaglandins, and ergot alkaloids. And uterine balloon tamponade can be done. If this stepwise is not responsive, PPH is not responded with this stepwise management. Surgical measures can be done like uterine arterial ligations. To save the mother, we can, there are incidents where hysterectomy can also be proceeded. Tears and trauma, bleeding from the areas of trauma should be sutured immediately. Uterine rupture and extension of uterine angle should be examined by exteriorizing the uterus during C-section. So extragenital causes of tears like subcapsular liver caps rupture and rupture of ovarian and splenic vessels can be seen. So inspection during cesarean by exteriorization of the uterus. The ultrasound helps in identifying a free fluid in a patient with uterine rupture. So management is by repair of these lacerations or genital tract trauma. Pelvic arterial embolization also can be required if there is a cases of broad ligament or supralevator hematoma. Retained tissue, retained placenta of membranes can be identified during bimanual examination. So examination under anesthesia can be done. So management is by manual removal of retained products under regional or general anesthesia. So coagulopathy should be ruled out when it's continuous bleeding with a contracted uterus. Investigations like full blood count, coagulation profile, and serum urea electrolytes can be sent. So immediate replacement of blood and coagulation factors, platelets should be done. Surgical only with trauma or atonic PPH unresponsive to medical treatment, we can go for surgical. So attempt should be made to identify the cause in a woman who is bleeding in parallel with resuscitation. Next slide, sir. So rationale for the development of carbetocin in new heat stable formation. So carbetocin is available in a room temperature stable formulation and convenient via vial presentation. So oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. So heat stable oxytocin is currently not available. So poor countries do not always have a proper cold chain transport and storage capabilities. So oxytocin is stable at room temperature, has a shelf life of 24 months at 30 degrees Celsius, avoids need for cold chain storage, and is provided in a vial. So when compared with the physiological management of PPH, prophylactic drugs reduce the risk of PPH by 66%. So active management of third stage labor should be done, and the drugs should be selected accordingly. Next slide. So use of fetotonic agent for control of PPH, time of administration only done after the delivery of baby, but before the delivery of placenta. Prophylactic use for the prevention of PPH, active management of third stage labor, and therapeutic use for the management of PPH. So what are the molecules used as an fetotonic agents are oxytocin, carbetocin, ergometrin, and symptometrin, and misoprostol. Next slide. Next slide. So carbetocin is a next generation drug, first described in 1974, approved for a medical use in Canada and UK in 1997. First Indian approval received in a year of 2020 and made available in 2021. So oxytocin molecule has been modified where a disulfide bond is replaced with an ether bond. Amino group in a cysteine is replaced, and hydroxyl group in a tyrosine group is replaced with a methylene group. All these has been done for a carbetocin. This several modification has done to prolong its half-life and reduce the enzymatic degradation. So carbetocin molecule is therefore more resistant to the aminopeptidase and disulfidase cleavage, thus reduces the chances of enzymatic degradation. So drug is not a synthetic long-acting analog of oxytocin. Therapeutic indication for prevention of postpartum hemorrhage due to uterine Etoni. It is available in a form of 1 vial 100 mcg carbetocin in 1 ml of solution. It is heat stable, no cold chain is required. Stability is maintained over 36 months at 30 degrees Celsius and 75% of relative humidity. Well suited for Indian practice, taking considering transport facilities and tropical environment. Next slide. So in coming next slides, efficacy and safety of carbetocin over oxytocin will be discussed. So compared to the oxytocin is a synthetic cyclic peptide form, naturally occurring posterior pituitary hormone, binds to the oxytocin receptors in uterine myometrium, stimulating the contraction of the uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. It can be given in a form of both IV and IM. Immediate action is seen when it is given in intravenous form, and the peak of concentration occurs after 30 minutes. IM slower on onset of action, taking 3 to 7 minutes, but produces the long lasting up to 60 minutes of action is seen. Half-life is about 1 to 6 minutes. So oxytocin requires protection from light, storage at 2 to 8 degrees continuously to preserve its activity. Whereas carbetocin is an heat stable, long-acting synthetic analog to oxytocin with agonist properties, binds to the oxytocin receptors in a uterine smooth muscle, resulting in rhythmic contraction and also increasing the frequency of existing contraction and increased uterine tone by influx of calcium ions. So this also can be given at both forms, IV and IM. It causes sustained uterine contraction within 2 minutes, lasting for above 6 minutes and followed by rhythmic contraction for 60 minutes when it is given in IV form. Whereas in IM form, these rhythmic contractions are maintained for up to 2 hours. Half-life is about 40 minutes. So storage condition, it can be up to 30 degrees. So indication for the oxytocin use, induction of labor, oxytocin can be used, whereas carbetocin cannot be used. For augmentation, oxytocin is used and carbetocin cannot be used. Prevention of PPH, yes, we can use both oxytocin and carbetocin. For treatment of PPH, oxytocin can be used. Next slide. So this champion trial was done by WHO, where carbetocin hemorrhage prevention, largest clinical trial in prevention of PPH has been done. So study non-inferiority double-blind randomized trial was done to compare the effectiveness and safety of this heat-stable carbetocin to oxytocin in preventing PPH after vaginal birth. Around 30,000 women were across 10 countries, including India, were enrolled. So primary outcome was there is a comparatively less blood loss, at least 500 ml after giving this carbetocin. There is no use of, not requirement of any additional uterotonic agents. The proportion of human with blood loss of less than, the proportion of women with blood loss of at least 1000 ml was studied. Next slide. So when compared with efficacy and blood loss, is there is a marked difference between 0.1% difference in more efficacy was seen in carbetocin. For blood loss greater than 1 liter, 1.5% efficacy is seen with carbetocin, whereas 1.45% in oxytocin group. Any adverse events were not, safety profile was also done. So any adverse event was not seen with the carbetocin compared with oxytocin. So the frequency of blood loss of at least 500 ml or use of additional uterotonic agents with carbetocin was proven to be non-inferior to oxytocin. The use of additional uterotonic agents, interventions to stop bleeding or adverse effects did not differ significantly between two groups. So in conclusion, carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of any additional uterotonic agents were not seen with the carbetocin group. Next slide. Next is an Cochrane review where review data was done from the 11 studies, including 2,635 women. For women who undergo cesarean section, carbetocin is resulted in statistically significant reduction in the need for a therapeutic uterotonics compared to the oxytocin. Also, carbetocin is associated with a less blood loss compared to the symptometrin in prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next slide, please. So different guidelines have been displayed here, whereas WHO recommends the uterotonics like oxytocin, carbetocin, misoprostol, ergometrin, and can be used in a combination also. Whereas this Canada Society recommends carbetocin 100 units IV bolus, whereas New Zealand body recommends active management of third stage with a prophylactic uterotonics. FIGO recommends a carbetocin one dose, one single dose is recommended for PPH management. This is German, Austria, Swiss body recommends carbetocin slow IV. France FCOG recommends carbetocin. Next slide.
Thank you very much, madam. Now coming to your experience with, these are some
yes,
of the things you shared.
Yes, sir. So coming to the in normal delivery where the active management of third stage labor is done before the delivery of placenta, this uterotonic agent can be given. So control cord traction and delayed cord clamping. All this results in a prevention of PPH. So many case studies was done to demonstrate the carbetocin is as effective as or potentially more effective than oxytocin in preventing PPH coming to the vaginal deliveries. So significant reduction in blood loss and PPH rates were seen with carbetocin. So may offer advantages in duration of action, particularly when given in intramuscular form. So it's an stable carbetocin, which is approved by WHO also. So which in modern obstetrics, it plays an important role in preventing PPH. Next slide, sir. So many meta-analysis was done as concluded that in reduction of PPH and in there is no further use of any additional uterotonics like while giving bolus of oxytocin receptors is not required. And use of other additional uterotonics is also not required with the carbetocin group. Next slide, sir. So carbetocin is in C-section, it is more effective. It's an alternative to the oxytocin for preventing postpartum hemorrhage in high-risk pregnancy group also. So conditions like where pre-existing mild cardiovascular disorders like preeclampsia, we can give this heat stable prolonged uterotonic carbetocin can be given. Next slide. Next slide, sir. So in conclusion, carbetocin is an superior to oxytocin in preventing PPH in vaginal delivery and can be popularized in the clinic.
Madam, thank you very much for your inputs and insights. A few panel questions I will go through.
Okay, sir.
What is the patient profile where doctors can anticipate a PPH?
For maternal conditions like teenage pregnancy, elderly primary gravida, multiparity, grand multiparity, who have inadequate prenatal visits, low social
Okay,
status, previous section. Coming to intrapartum condition like your prolonged induction or augmentation of labor, VBAC,
okay,
the second, the arrest of second stage of labor, like abruption, all these conditions we can anticipate PPH. Coming to the fetal condition like polyhydramnios, large for
yes.
gestation age babies,
Twins maybe.
we can anticipate PPH.
Even conditions like fibroid or twins can also predispose the patients, where
Yes.
uterine atonic can be affected.
Yes, sir.
Can we use carbetocin in case of retained placenta? Any experience you have, madam, on this?
Yes.
For how long you have been using carbetocin, by the way?
Since about 1 year, sir.
1 year, very good.
1 year.
So,
So
do you have any experience of use of carbetocin in retained placenta?
yes, sir. If there is no placenta is not expelled within 30 minutes, we can use this carbotocin intraumbilical like we use oxytocin.
Yeah, yeah.
Manage the removal of placenta with the lower blood loss, and it cuts short the third stage of labor.
Okay. So first of all, manual removal of placenta is necessary. After that, it can work.
It can, yes, sir.
And your experience in case of RH negative mothers?
Yes, sir, it can be used without any
Can be.
issue. It's not related to the any RH incompatibility,
Yeah.
and it is not reacts with the RH factor. So we can use
Okay.
in RH negative mothers.
Now, many doctors use oxytocin for labor induction. In those doctors, in those patients, can we use carbetocin for prevention of PPH because both oxytocin and carbetocin will act on the same receptors?
Yes, sir. Carbetocin can be used after oxytocin. So as it is provides a prolonged uterine stimulation. So prolonged use of oxytocin causes this desensitization of receptors.
Correct, correct.
So heavy bolus oxytocin after delivery of a baby to prevent PPH can, in this condition like desensitization condition, can in that conditions we can use carbetocin. So even
Carbetocin,
for induction, we can use carbetocin for prevention of PPH.
PPH. So irrespective whether the doctor has used carbetocin, I mean oxytocin or no, we can use carbetocin for prevention of PPH. In
Yes.
short. In which cases, what is the route you generally prefer, madam? You have been using it for over a year. So what is the route you generally prefer?
Sir, IM route is more preferred as it
More
is
preferred.
prolonged action is seen
Duration of
for
action.
for
Yes.
2 hours can be seen.
Correct, correct, correct.
So IM route is more preferred actually.
More preferred. And IM route may not require even IV lines and anesthetists and other things. It has the facility of straight use.
Yes.
In fact, that's one thing which differentiates this drug from others.
Yes, sir.
What is the adverse effect profile of carbetocin? Have you seen any severe adverse effect or something like this with carbetocin?
No, sir. In my
No.
practice, I have not seen any
Not
adverse cardiac event,
correct.
hypotension, or any this thing. In fact, with the oxytocin rule of three,
Yeah.
I have seen with like hypotension, arrhythmias, all this have been seen with oxytocin.
ADH adverse effect is also there. ADH related adverse effect.
Yes, sir. But with
Yes.
carbotocin, all this
Nothing.
like patient inconvenience was not seen, like chest pain, chest heaviness. We have not seen with carbotocin.
Okay. If the patient is not responding adequately with carbetocin, then what next? Whether dose can be repeated or what additional uterotonics you use?
Like the other additional uterotonics like methyl argometrin, carbopros, PGF2 alpha, or misoprostol can also be used, sir.
Madam, now you have been using it over 1 year. Do you routinely use it in all patients or you use it selectively?
I use it selectively, sir.
Selectively. In which patients? Those patients who are at risk of getting PPH.
Yes, sir. Yes.
Okay. And
As
you will use intramuscular route.
yes, sir. Yes.
What are the advantage of carbetocin over other uterotonics?
So advantages is its room temperature stable and less or no requirement of any additional nutrotonics. Single fixed dose can be used. It's like repeated dose are not required. Faster action and sustained therapeutic effect is seen. Action begins within 2 minutes and lasts for over 2 hours.
2 hours.
So oxytocin receptor desensitization, which happens with oxytocin doesn't happen with carbetocin. So 50 times more potent than endogenous or exogenous oxytocin. It's also around 40 times more greater than oxytocin. So these are the advantages we have seen with carbetocin.
Should it be kept as a reserve drug or a first line drug?
So carbetocin can be considered as a first line agent, sir. Current evidence suggests the use of carbetocin as an alternative to oxytocin as a first line agent. It has found its own place in modern obstetrics. So it can be as a first line agent. So prevent.
Yes, and we know the risk with PPH. I mean, PPH is a very deadly condition if it occurs, but plus. So better use carbetocin, which is a good drug, as a first line therapy rather than keeping it reserved.
Reserved, yes.
So is there any role for anesthetist in deciding the drug for prevention of PPH?
Yes, sir. Anesthetist plays a critical role by assessing the risk and maintaining the hemodynamic stability.
Correct.
Using the appropriate drugs in collaboration with the obstetrician.
Yeah.
So they plays an important role.
So do they tell which one to use, or do they follow you? What is the general sequence?
Generally, we go with a collaboration with obstetricians.
Yeah.
Where there is a quick history and rapid initial assessment.
Correct. So the obstetrician will say, you can start carbetocin, and the anesthetist will follow that.
Yes.
Something like that. Correct. To conclude, to give a take-home message to the audience, what will be your take-home message, madam?
This carbetocin is a latest uterotonic, a long-acting synthetic oxytocin. So it can be used in preventing PPH. Half-life is 8 times more than the oxytocin and 50% more potent than the oxytocin. So can be used for preventing as a first-line agent for preventing PPH, especially in high-risk cases where the risk factors is present, and elective C-section also. Right. For these high-risk cases, we can use this carbetocin.
Thanks so much, madam. Thanks for your time and thanks for your insights. I'm sure the audience has benefited out of your suggestions and comments, especially the way you're using it in intramuscular and the selected patients. I'm sure the audience has benefited. Thank you so much, and thanks all the doctors who took time from their schedule and attended this webinar. Thank you, marketing team and sales team of Heathrow for coordination, and thank you, IT team Heathrow for super support. Thanks all of you, madam. You can sign off. Thank you. Wish you a very good afternoon.
Thank you, everyone.
Thank you. Thanks, madam. Thanks, Nagadevi.
Thank you, sir.
Thank you, sir.
Sir, actually, we can